you get started? Not like each other.
Hereby, I open this academic ceremony in which Amourie Prentice will defend the academic thesis, Novel Interventions and Treatment Selection Predictors for Treatment-Resistant Depression. May I invite you to present a summary of your work?
Thank you. So my name is Amourie Prentice, and I am here to defend today my thesis, Novel Interventions and Treatment Selection Predictors for Treatment-Resistant Depression. Major depressive disorder, or depression, is a complex mental health disorder in which patients suffer from a constant feeling of sadness and or loss of pleasure and interest, and are associated with also cognitive and physical symptoms that severely affect everyday life. According to the World Health Organization, it is a leading cause for global disease burden and is a primary cause of disability. For depression, there are treatments such as psychotherapy and antidepressants. However, for most patients with depression, only a third as a first course will actually achieve remission. As they go on with their treatments, every failed treatment, the likelihood of responding remission decreases. And so this, once a patient has failed 2 or more antidepressant trials, patients are categorized as treatment-resistant depression, that they have that. And so this is why I'm here today to talk about the patients with treatment-resistant depression, and so what we can do for them, what do we know from them. So I'll go first in a little summary. Study 1 is about the rostral anterior cingulate cortex theta power, in which I analyzed over 500 patients, depressed patients, and I analyzed their EEGs, electroencephalogram. EEG is where a patient receives electrodes over their skull and over their heads, and it then measures the electrical activity of the brain. And on the picture, you can also see where the rostral anterior cingulate cortex is. For study 2, 3, and 4, I looked at the right lateral orbital frontal cortex as a target for TMS. And here you can see the right lateral orbital frontal cortex is at the front of the brain, and TMS stands for transcranial magnetic stimulation, in which is a non-invasive treatment for patients with depression, and it involves placing a coil over the head and having magnetic pulses go through the coil and stimulate the brain. For study 2, I analyzed 41 patients. Study 3, I analyzed 54 patients. And for study 4, I analyzed over 3,500 patients. So study 1 about RSCC theta. A little background. Why did we look at RSCC theta? Well, in 2011, Pizzagalli came out with a meta-analysis in which he concluded that baseline RSCC activity was a non-specific prognostic marker for depression, for patients with depression. This means that anyone who has high RSCC activity would likely do well on any kind of treatment. In 2018, with the EMBARK study, he again concluded that high RSCC theta this time is a non-specific prognostic marker for a treatment response, and this was proven with sertraline and placebo. On the other hand, in this meta-analysis from 2011, there were 4 studies that showed reversed findings. And this was also found in the iSpot-D study in 2015, where high RICC theta was actually correlated with non-response for patients who had escitalopram, sertraline, and venlafaxine. And this was more prominent with patients who had previous failed treatments. And so a possible conclusion from that was that it's to do with treatment resistance. And indeed, in 2013, a paper by Hunter et al. Saw that RICC theta, when it was high, was predictive of response for antidepressant-naive patients, and then low had the reverse for antidepressant-experienced patients. And so the question was, for this study, is it a non-specific prognostic marker, and therefore a marker for treatment response, or is it actually for treatment resistance, showing treatment resistance? In this study, I analyzed 4 different groups of patients. One had done psychotherapy, one had done antidepressant medication. These were thought to be a first-line kind of treatment. So we put them as treatment resistance as low. Then rTMS is same as TMS. They had a higher level of treatment resistance because they had to have failed medication before starting this. And ECT, electroconvulsive therapy, is then the 3rd line of treatment. And this was a naturalistic retrospective study, so we were looking at data that had already been taken. For results, we found that baseline RICC theta was had a significant difference between remitters and non-remitters for patients who underwent antidepressants. High RICC theta was found in remitters, and lower was found in non-remitters. However, we did not find it in any of the other treatment modalities. RICC theta was also found to be correlated with treatment resistance because, as we can see with the graph, it's kind of similar for psychotherapy and AD, so first-line treatment, and then increases as the treatment resistance also increases, so rTMS and ECT. And we're concluding this that is stable because when mediated by frontal theta, the line stays similar. So we conclude that RICC theta is not a reliable biomarker for treatment response, but does index treatment resistance. So moving on to study 2, 3, and 4, in which I looked at right lateral orbital frontal cortex as a target for TMS. A background. In TMS, the most commonly used target is the dorsolateral prefrontal cortex, DLPFC. And again, a lot of patients do well on it. However, there are patients who do not improve from it. So we see a bimodal distribution. So what can we do for those patients who don't respond to DLPFC? Well, Edmund Rolls came out with the non-reward attractor theory of depression, which is looking at the right lateral, at the orbital frontal cortex. He says that the lateral side is there for non-rewards stimuli, so that activates when you see a non-reward, and the medial side of the orbital frontal cortex activates when you see rewards stimuli. During depression, this lateral side is overactive and the medial side is underactive, and so you will come into a rumination state where these negative thoughts persist. And so we thought that right lateral or orbital frontal cortex could be a good target in depression for TMS. So the second study here looked at 2 different groups. One is from the Netherlands and one is from the US. We're looking at patients who had failed dorsolateral prefrontal cortex and then had either a switch to the OFC or an add-on to OFC. These groups also differ in target for OFC, which is FP2 for the Dutch sample and AF8 for the American sample. We find that for both groups, there's an overall improvement with remission rates at 24 and 31.3%. We see that depression severity scores also get better with OFC. There's an improvement in the BDI subscales in anxiety and sleep scores. However, when we looked at if there was any predictive association with remission, we didn't find any with the demographic and clinical characteristics. For study 3, we wanted to redo this study, but then see what would differ when you did a full course of dorsolateral prefrontal cortex and then switched to orbital frontal cortex. And so it was a 36 session and then 36 session with a switch, and the target was this time F8. Again, there was an overall improvement with 16.7% remission rate. There was an improvement with the depression severity scores. There was an improvement for sleep, suicidality, and rumination proxy, and then also in anhedonia, but only for women. And when we looked at predictive associations, we did not find any associations for improvement. When looking at the trajectory of the depression severity scores, we wanted to know whether it was really due to the switch of OFC that it made patients improve, or whether it was just the amount of sessions that they received. Berlo et al. Came out with saying that if you see an exponential decay function in the trajectory curve, then it means that there's an actual cause, and that reason is why patients got better. And in this study, we saw that when they did a switch in the dorsolateral prefrontal cortex, we do not see this with the responders, but then once they switch, there is a steep decrease in their PHQ-9 scores, and then it plateaus a bit at the end. So this is why we're saying the switch is the reason why. And so here I conclude that right lateral orbital frontal cortex is a promising alternative target for TMS for patients who were unresponsive to conventional dorsolateral prefrontal cortex TMS. Next, we wanted to know whether adding OFC for TMS-naive patients at the beginning of their course would actually do better for them. So we compared two groups, one who got sequential bilateral DLPFC versus a group who received a hybrid OFC protocol in which it's dorsolateral prefrontal cortex to the left side and right OFC to the right side. And this target was F8. The groups did not differ except on number of previous failed antidepressants, but this is likely more just clinical relevant instead of just significant. No, it's significantly relevant, however, clinically, because there's only one antidepressant, we didn't pay too much of attention to that. And so for results, in the PHQ-9s in response and in remission, we see no difference between the two groups. And in the GAD-7, again, we see no difference between the two groups. For predictors, when we looked at multiple predictors to see if there was association with improvement. For both protocols, it was women and fewer failed antidepressants that showed prediction for improvement. For sequential bilateral DLPFC protocol, it was the same, but also longer illness duration and less rumination. And then for the hybrid protocol, it was lower baseline anxiety severity. And so for conclusion, RSCC theta was not a reliable biomarker for treatment response, but does index treatment resistance. The right lateral orbital frontal cortex is a promising alternative target for patients with MDD who failed DLPFC TMS. The hybrid protocol of right lateral orbitofrontal cortex and left DLPFC does not seem to be offering more than conventional sequential bilateral DLPFC TMS for TMS-naive depressed patients, and more research needs to be done to find reliable biomarkers. Thank you.
Thank you very much for your presentation, which was done exactly in time. The opposition will be opened by Professor Theresa Schumann, who is, holds a chair in the cognitive neuroscience of non-invasive brain stimulation. The floor is yours.
Thank you very much, Prorector. Dear candidate, let me start off with congratulating you to this beautiful thesis. It was a pleasure to read, and I really enjoyed your summary of your work just now. I think it's very valuable that you look at other stimulation sites, not only DLPFC. So I really enjoyed reading your studies. I'd also like to extend my congratulations, of course, to the supervisory team, to Alex and Martijn, and of course to Nikita, who is following us online because she's heavily pregnant and couldn't travel here. I have some questions about chapter 4 and 5. And in chapter 4, you actually describe clinical improvement in patients who were switched from bilateral DLPFC stimulation to right lateral orbitofrontal cortex stimulation after, I think, about 36 sessions of non-response. However, there are a few studies out, such as, for example, the one from the group of Joanne Combodon, that say that quite some patients who were still non-responders at session 36 actually do achieve response or remission when they get extended DLPFC stimulation. Yep. Some even still respond at session 72. How can you be confident that the improvement in your study was actually due to the switch in stimulation target rather than a simply delayed stimulation effect of DLPFC, for example, or if you had continued with DLPFC that you would have seen the same response?
Highly esteemed opponent, thank you so much for those complimentary words and for your question, which is a very important question for this study. I would want to say first that from the trajectory, this is by seeing the exponential decay function, that's why we're concluding that it was the switch that was the reason why we're saying it was the cause for them to get better. However, I do agree that it is possible that if they had continued on, there is also a percentage in those patients that would probably have done better with DLPFC. So, but from looking at the curve, it may have been a very slow response, while with the OFC, they improved significantly. And so if I were to be in the clinic, I would probably say to them, do OFC, and then you would get better faster than if we continued on for longer.
Mm-hmm. So what you're saying is you looked at the analyses and saying the steep improvement you then saw on group level, you would say, okay, this shows that it was actually OFC rather than DLPFC. How would that be in an individual case then? Because as a patient, I don't care about group data. I want to know about myself. So how would you, could you also predict that somehow then? Or is it that you can afterwards?
Yeah. Always looking afterwards is easier. I think already looking at DLPFC, their trajectory there, and seeing that it wasn't going very fast, and it's also up to the patient maybe of determining, okay, these are your two options. We're seeing that DLPFC is improving slowly. You can go on, we can go on if that feels good for you. However, if you want, we can do OFC, which for a group of patients, it seemed to go much faster. So this is a possibility for you to go faster. However, if you don't feel up to it, then you keep on going with DLPFC, and we see with that.
Okay, that's clear. And then if I look at chapter 5, and of course this is probably a question you would have expected, but there you do this hybrid protocol where you combine right lateral orbitofrontal cortex stimulation with left DLPFC stimulation. And you compare this to a standard bilateral DLPFC protocol. And you actually see no difference between those two. Yet in chapter 4, you say, well, the switching makes sense to actually stimulate another side. Now you suddenly stimulate both sides. What does this imply about the role, potential role of the right lateral orbitofrontal cortex? Because you say, well, it might be good as a second line. Why not as a first line then?
Yeah. From this, we're seeing that a second line, it would definitely work. As a first line, it didn't seem to work as well. However, if I were to go back, I would choose a different target than F8. I'm finding it a little too far back versus what orbital frontal, according to Dr. Edmund Rolls, would have said. And so maybe if we had redone the FP2, with FP2 as an OFC target for the combination protocol, I think that then we would see a difference there. So I would still like to see if it could be used as a first-line treatment for these patients, yeah.
And imagine now, I get that this is all just an imagination, but imagine you were on the right spot, and now we're saying, well, it only works if we do DLPFC stimulation before. How could you explain this more mechanistically? Like, would the DLPFC stimulation be a door opener or a priming, or do you have any ideas about this, about network effects, or?
Yeah, from what I hear from patients or from the psychiatrists, what I usually hear is that patients come in and they do dorsolateral, and it gets better, but not to a huge extent. And then they come in saying, okay, you didn't maybe treat the depression, but you treated something else. But now this has come up as a symptom that I'm really struggling with. And then they do OFC, and then that seems to go away, and they seem to be more open again for, it's just, I think 2 different networks are working. And so it depends on what the patient is suffering most of. Is it in that first network, or is it in the second network? And knowing that from the start would be great to know which one to target first. And then, yeah, with newer protocols that are coming out, newer medications that are coming out, it may be possible to just target both at the same time and see more improvement.
So this argumentation would only work if we then said we were really on the wrong spot with OFC for you, right, so. In your study? Because otherwise, would there be an argument, or could you think of why, even if we were on the right spot and we stimulated both networks, why we wouldn't see the response or wouldn't see a difference?
Yeah, I'm not.
There's no clear answer. I mean, we could also say that this is just something we would have to.
I would love
study
to.
still.
Yeah, I would love to study it further. Yeah.
Okay. Thank you very much.
Thank you.
1 more minute, or okay, good. Yeah, maybe this is. But I think you have answered this already. What would I offer patients then? Because you say, okay, some of the patients, they get DLPFC stimulation. They say, I react quite well to this, but now these symptoms come up. So if you get a patient now, would you actually ask them what kind of symptoms do they have, and based on that?
Oh, definitely.
And what would make your decision? So what symptoms would patients have to show that you go for OFC rather than DLPFC?
Yeah. If their everyday life is, like they're troubled by doing everyday life things that involves cognitive functions, then I would offer the DLPFC. If they're actually doing really well every day and they come to work and seem fine, but it's actually that they have a ton of negative thoughts that just keep persisting all the time, then I would give OFC.
Okay.
Yeah.
Thank you very much.
Thank you, Professor Schumann. The opposition will now be continued by Professor Pim Drinkenburg, who holds a chair in Translation Neuroscience for Psychopathology at the University of Groningen. The floor is yours.
Thank you, Mr. Prorector. Dear candidate, allow me to first thank Maastricht University, especially your supervisors, for giving me the opportunity to review your thesis and to discuss some of the contents with you today. I really like to compliment you and your supervisory team with the thesis. I really think it's impactful work, and it's very nicely documented. I also enjoyed reading the comprehensive introductory and also the to-the-point discussion with all the chapters, apart from one, I think, already being published, so my compliments. There is, however, a topic that I would like to discuss with you, and perhaps challenge your expert opinion a little bit, or maybe I misunderstood and you can educate me here. And that refers to your proposition number 6. Perhaps one of your paradigms can help out here.
Aside from using personalized strategies, TMS outcomes could also be improved by targeting multiple networks in the same protocol to address coexisting transdiagnostic dimensions of illness in a given patient.
Thank you. I think if you read this proposition a number of times, you get very enthusiastic because it's a very promising proposition, I think. Although I have to say I've been working in drug discovery and development for quite some years in pharma R&D, and there is generally accepted that also for precision neuroscience or personalized strategies, that pathology, if we understand at all what the underlying pathology is, it has a very limited match with disease categories. So drugs work or fail quite often on the pathology and not on the disease category. You may say the same about symptomatology. So basically, drugs work or fail in a network and not on disease categories. And that's where the network comes in. There was last year a very nice paper by Mirta Ronde and co-workers who gave an overview of the default mode network dynamics. And in that, she also put an emphasis on social dysfunction, and that many networks that involved in that are also shared between depression, schizophrenia, and even Alzheimer's disease. So when I read your proposition that states that TMS should target multiple networks in the same protocol, I fail to understand exactly how do you see this then happen in the future. And how do we understand that? In pharmacology, we can target maybe with a subtype receptor and a specific brain distribution, some specific networks. But in this case, how do you do that? So my question is, what I appreciate about your thesis is the use of increasing precision, parameterization, and insight in TMS. I really appreciate that work that you do. But in proposition 6, you seem to sort of argue just to shoot from the hip in a trial and error fashion on multiple networks. But hopefully you can explain to me exactly what you meant with that proposition.
Highly esteemed opponent, thank you so much for your kind words and for this interesting question. I think I would say from this targeting multiple networks, I'm talking with the TMS in mind, is that some patients may actually need both the salience network and the non-reward network to be targeted. And therefore, a combination protocol, such as the hybrid one, would probably be best for them, because then you would be improving their cognitive functions, but also their negative thoughts. From the study that is in this thesis, we would think that actually that doesn't work, which is actually possible. I just have some reservations for the target that was used. Unfortunately, this was naturalistic data, and so this is what I was working with. And then also, yeah, as the target was F8, and there's a possibility that F8 was closer to the ventrolateral prefrontal cortex and therefore connected to the salience network. We maybe have just been targeting only the salience network, and that's why I would rather do another study with FP2 in mind. And then I do think that something would come out of it for patients who actually need both networks stimulated.
In your proposition, you phrase it, I think, and correct me if I'm wrong, but you phrase it much more broader in the sense of transdiagnostic dimensions. Can you indicate how we could realize that? Do we need additional biomarkers then to maybe upfront select other networks? And what kind of tests would you think of? Especially for the transdiagnostic approach, to keep it understandable.
Transdiagnostically, what is coming to mind, and especially because it's OFC, is that, for instance, obsessive compulsive disorder is also connected to the non-reward network, because they have intrusive thoughts that come repetitively and can't be stopped. And so for that, that's a transdiagnostic way of looking at OCD and depression together, in which I think OFC TMS would probably benefit them. With other networks, it's not coming to mind right at the moment, but yeah, that is, yeah.
Can I still have one question? There was one specific transdiagnostic symptomatology that came to my mind, and I just wondered whether you have come across anything in that direction, and that's social withdrawal. Because social withdrawal is, of course, a behavior you see in depression, you see it in Alzheimer's, you see it in schizophrenia, and also other neuropsychiatric disorders. Would that be a candidate for what you call in your Proposition 6 sort of other networks that you may co-stimulate, or do you feel that would be only possible if you have more knowledge about that network? What's your thinking about that?
Well, I do, as you said, Alzheimer's, I am thinking of how TMS also can help for Alzheimer's. Not that it takes it away, but it is improving their cognitive functions, which is what they are losing. And that would probably be stimulating the DLPFC and therefore the salience network. But that's the only thing that's coming up to mind at the moment for transdiagnostically and how we can use TMS. I suppose also if it was for social behavior, you could also think they are getting negative thoughts about what is around them. By giving an OFC stimulation, you would be telling the brain to stop thinking negative. There's nothing wrong with, they're not thinking badly about you. You don't need all those negative thoughts. Why don't you just ask them, what do you think of me? And so, yeah.
Okay, thank you.
Thank you.
Thank you, Professor Drinkenberg, for your questions. The opposition will now be continued by one of the members of the opposition who is online, Professor Martijn Viguet. He holds a chair in psychiatry and neurosurgery at the Icahn School of Medicine at Mount Sinai.
Dear candidate, congratulations. I really enjoyed reading your thesis, and I'm honored to be here for your defense. I'm a big fan of TMS, and I think one of the unique aspects of TMS is that it's a brain-specific treatment, unlike many of our other treatments that we have in psychiatry. I think it's extremely promising, therefore, that you helped unravel some of the potential brain markers of TMS and also explored different brain targets. So my first question is about your chapter 2 rostral anterior cingulate marker, the low frequency theta brain oscillations that you find with EEG. And I think you've, as far as I understand, you find that this marker is basically increased in people that are further along the treatment protocol, like TMS or ECT, versus the ones that are earlier on with psychotherapy or antidepressants. So I wanted to know, how do you interpret, can you speculate about what do you think the meaning is of rostral anterior cingulate theta? And how is it associated with refractoriness of depression? And maybe the first a way to think about this is theta is low frequency. How do you think that's different from high frequency? What do you think is the meaning of the fact that you find specifically low frequency oscillations to be the marker?
Highly esteemed opponent, thank you so much for your kind words, and thank you for the question, which is a very interesting question. I think with, at least, so with theta, what is known is that it is found mostly in the hippocampus, and that is also connected with emotional regulation and also with memory. So emotional regulation for sure, as your states of depression may increase and that you get more treatment resistance, maybe you will be becoming less able to do emotional regulation, and therefore that is a reason why it increases.
Is there, the difference between low and high frequencies in the way they just generally function in the brain? I think high frequencies are, well, maybe you can speculate about that. What's the difference between high and low frequencies in the brain?
So high frequencies such as like gamma and that is usually also found for cognitive functions. That difference.
It's also.
I
so
just.
High frequencies. Go ahead. Yeah, sorry.
No, please go ahead.
There's a bit of a delay, so the high frequencies are also often thought to be more local, reflecting more local functions, whereas the low frequencies are usually relevant for longer range network function. So it seems that you find a specific, like a network marker. So how do you think rostral anterior cingulate theta influences, or maybe a marker of the network? What do you think is the network function of that region and the marker you find?
I would want to say maybe as depression develops and it becomes more resistant, that also the network itself is becoming more resistant to any kind of treatment, or is a depression network is therefore intensifying, and therefore this RSCC theta, the low frequency, is then maturing and becomes higher as the treatment resists.
Yeah, no, I like that explanation. So you think it may start more locally, and then as the depression evolves and gets more refractory, the larger network is more affected, which makes it harder to treat, right? So I think that's a good explanation. But which network do you think the rostral anterior cingulate is most relevant for?
Unfortunately, at the moment, it's not coming to mind which network.
Yeah, I think you have it in your. I mean, you've written it in your thesis. I think you pointed out as part of the default network, right? And talking to the salience and central executive networks. One of the questions I had, and maybe also thinking about these networks, is why do you think the orbital frontal cortex, the TMS at the orbital frontal cortex, was more effective for the American patients than the Dutch patient, which to me was an interesting finding?
That one, I would say, is there are loads of differences between the American and the Dutch sample. The American ones, they added on much earlier than the Dutch sample, with about 24, I think, sessions of DLPFC, and the Dutch was at 42 sessions. So
Right.
First of all, I think there's a difference between how resistant they were already to maybe in that way. There's also a difference in the amount of women in each group. There's a higher number of women in the American group versus the Dutch group, which I think was more 50-50. And women are known to do better with TMS. So I think there you can see as well why there would be a steeper
right, okay, so that's fair. So you think the studies, the two populations were not completely comparable, and also, as I'm familiar with in the US, they didn't wait long enough, right, before switching. So they may have actually also responded to that other target. Now, I think the orbital frontal cortex, at least that's what I always presume, other than just negative thoughts that you also mentioned in response to the previous questions. I think it's also important, if you think about the network function of the orbital frontal cortex versus the DLPFC, your other target, what do you think, what symptoms different from just negative thoughts which you expect? And I think you find some of that in your studies, are more responsive to OFC TMS than DLPFC TMS.
Comes back to anhedonia, which is then that
right.
loss of pleasure, and that's from the orbital frontal cortex, but then the medial side, and the lateral side is connected to the medial side. So if you're targeting the lateral side, you will be also targeting, technically stimulating the medial side, and so both should be, both will have improvements. Yeah.
Right. So you think it's more of an anhedonia target, the orbital frontal cortex?
The cortex is definitely for people who ruminate and who have anhedonia. Yeah.
I think
right.
I have to interrupt this interesting conversation at this point. Thank you, Professor Viguet, for your questions. And the opposition will now be continued by Professor Blokland, who holds a chair in comparative neuroscience at FPN.
Thank you very much, Prorector. First of all, of course, my congratulations for this nice piece of work, nice set of data, interesting novel insights, hopefully, in treating depression, which is, of course, as you mentioned several times, a really important issue. Of course, I also want to congratulate your supervisory team who helped you with this endeavor to find more evidence to how to treat depression. I'm a little bit more from biological background. I will not ask a question about that, by the way, but it's quite amazing to me because I think that depression is a more systemic disease. You also relate to this immunological changes that take place, the brain-gut axis, and then you see that with just stimulating the brain, you seem to modulate that systemic disease. So that's quite interesting to see that. I just have my first question. I hope it's a quite simple one, because if I look at table 2 at page 98, I see that when you look at the effective response, there's no difference between, no effective response. But when you look at figure 2, you see a huge difference between the two. So what are these two analyses tell me, and how should I interpret the non-effect in this analysis and then see the difference in the graph and the effect there?
Highly esteemed opponent, thank you so much for your kind words, and thank you for the question. I think from this significant difference is actually between males and females. And so there was no difference between males and females for response. And so, yeah.
Okay, that explains the whole thing. Okay. Yeah, the interesting finding from this study is, of course, that is also many other studies found that the females are more responsive than the men. And in this chapter, in the discussion, you give some explanation, but but I didn't read something about a placebo effect. That females might be more responsive to a placebo effect. So I know I had a good chat with my friend PT, and that told me that men are have a higher placebo effect when it's about pain, But when it's more about emotional things, then females are more responsive for placebo effect. So couldn't you explain these findings in terms of a placebo effect, the sex difference?
I mean, it is possible that there is a placebo effect. However, there are other studies that have seen this over and over again with large samples that indeed females just do better on TMS than males. But again, yes, there is a possibility that it is a
but the placebo effect could be taking place everywhere.
Yeah. But yeah, it's just then I think that with this study, just seeing this difference only found of a difference in anhedonia, but then not that there was no difference between men and females in the actual depression scores just means that TMS was working for both of them very well. But I thought it is interesting to see that it was only found for anhedonia for females, and at this moment I don't really have a reasoning on why it was just for the anhedonia part.
Okay, yeah. So that leads to my next question for this chapter. So it's also about you rely heavily on item scores. So it's only one item that you draw all these conclusions. So how fair is it? I mean, you alluded at a little bit in your discussion that maybe you should have a real good scale for anhedonia or for suicidal ideation, for example. So how, I think you rely too strong on this one item, or is that maybe too skeptical from my side?
No, I think it's a fair point to say that it was only done with the items of this scale. I think a lot of studies do similarly of looking at just the items, but as I would say in the conclusion is that if to be redone, it would be with other scales. And again, unfortunately, this study was with naturalistic data, so I had what I had.
Okay.
But yes, it would be great to redo the study and do it with an actual anhedonia scale and an actual rumination scale and so on, and see really how it differs. Yeah.
Okay. Well, of course, not everything can be done in one, even not in 4 years. Yeah. I agree. I would like to move with you to chapter 5, and there you have even more numbers of participants. I have actually several questions to that. Yeah. First of all, you put together a large group, and actually on page 122, you show actually not much of a difference between these groups. But based on your title, and I see it here in front of me, so selection predictors. So actually when you put all these people together in one big group, then you're missing out the specific people that could respond and people that might not have responded to this treatment. So could you do an ad hoc analysis on these data and to see whether maybe there are some, I'm not sure whether you have predictors in this data set, but could you maybe get hold of some of these predictors?
So we did find some predictors. When we looked at the whole group of everyone together, then women and I believe it was fewer failed antidepressants that came out as significant to predict improvements. And then we divided them between the two protocols. The sequential bilateral protocol then had the same predictors, but then on top of it, longer illness duration and it's in my slide, and one other one, longer illness duration and.
Okay, another one.
Yeah. And then the sequential hybrid OFC one came out as only lower anxiety scores came out as predicting improvement. Sorry. Even more, like if we could go further, yes, then we could go to other scales of going to between men and women into those groups. Could go into if they had any other treatment failures, for instance. There's lots that could still be done. Yeah.
Okay. But do you think that it would be good, for example, if you would have to construct a new study to really show the effect of whichever part of the brain you want to stimulate, to be the most effective one? You mentioned somewhere you would like to have a bigger group size. In chapter 4, you say you had too little one, too few, and then now you have so many. So where is the good balance to find that you can say, okay, and I think you need some selection criteria more than you use now for each stimulation protocol. So how would this ideal study would look like? I mean, you only have a few minutes now.
Possibly, on one hand, having a few, like a little group of patients and seeing what that gives is a good start. It says, where could we take the direction? And then testing it on a much larger scale is then also very good, because then we get to see, is it still standing?
But what about the selection criteria? Because I think that is, at least what I read from your thesis, a quite important one.
Yeah.
So, for example, would you like to test only women because then you see the effect? Or would you like also to test only males to give this, at least this part of the world some hope?
Oh yes, because women would be very different. Like, I also find studying women very complex. So many different criteria should be taken into perspective with women. So if I could choose, it would be the males that we look at only. But yeah, it would be an interesting study, a very complex study, to only look at the women and see how would they do also during their month, during the lifetime. Many studies to be done.
Okay, thank you very much. I give the word back to the prorector.
Professor Blokland, thank you for your questions. The opposition will now be continued by Associate Professor Frans Smulders, whose expertise is in the broad domain of cognitive neuroscience, and the floor is yours.
Okay, thank you, dear candidate. Also for me, congratulations with a nice thesis. I actually have a question about, a first question, a very general one about Chapter 1. There you discuss a number of TMS treatment studies, and you mentioned the presence of a placebo control condition in only one of them, and in that one, the effect of TMS was not any bigger than in the placebo control. Now it seems to me that TMS treatment seems to have all the ingredients for a very strong placebo effect. You know, people have to take the trouble to come to the lab many times, and they are told that you're going to give them direct treatment of their brain, basically, and there's this impressive clinician and a machine that's doing that stuff. So, from the perspective of a critical outside, for me the question is not whether there is something like a placebo effect, but just how big it is. You know, what proportion of the total TMS effect is in fact a placebo effect. So maybe you have some ideas about that. You can also draw from your clinical experience if the publications are not available. Then the second part of the question is, what do we know about this placebo effect? Like, how long does it last? And could it also interact with some psychopharmaca, that you're more susceptible to placebo if you've also been given psychopharmaca at the same time?
Esteemed opponent, thank you so much for your kind words, and thank you for, again, another interesting question. I wish I had more time this year to finish up this other paper that I'm writing on, which talks about placebo effects of just mentioning that the patient will have TMS. And it already shows that for, I don't know if I'm actually allowed to say it already, but I think I am because it is my data and it comes from this data, is that patients who respond to TMS already, there's a difference before treatment that they are already improving. So you do see patients that already knowing that they're going to get TMS, it is there. And once they get TMS, it does improve again. However, even for patients who were not responding before starting the treatment, if they are responders, it may be flat but it does still go down, and that's when a TMS is really the one that helps them. So yeah, it's coming out. I wish I had more to say about that right now, but I think, yeah, there is a placebo effect for some patients, but if that helps them, that's great, and then TMS will just improve that afterwards.
Yeah, good, thank you. I have another question about chapter 2. There you compare our ACC theta in EEG across groups receiving psychotherapy or antidepressants or TMS or ECT. And the idea is that you have an operational definition of treatment resistance there. And this seems entirely logical. So if you come for ECT, you probably had several treatments before, and therefore you're likely to be more treatment resistant. But I think your classification not entirely clean, because in people that come for the first time for psychotherapy, there will surely be people that are highly treatment resistant, but they just don't know yet because they haven't tried all those treatments. So what is the consequence of this bias in this group for your data?
I do agree that the way we were phrasing it is just the way we were taking this data. It's a first-line course, so we're going to assume that they are less treatment resistant, and when you go to TMS, you have had already 2 failed antidepressants, and according to the literature, that is when you are termed as treatment-resistant depression. So that's how I was visualizing it. If I were to redo the study, maybe then I would go more in depth about how resistant they are to treatments. How can you really clearly define each one as what level of treatment resistance they are, and that may come back as a more definite conclusion. But I think this is still a very good start of showing people that if you are in the first course of treatment, that your RCC theta could be quite low, and that then afterwards, the longer you are getting treatment, the higher your RCC theta increases. Yeah.
But still, something was puzzling me a bit about this chapter as well. So, you do actually treat people, after you've taken an EEG, and you can measure their improvement. So you have remitters and non-remitters, but actually you don't find the same results anymore. So you have an optimization of treatment resistance, which is a comparison across groups. But then if you look within the groups, you seem to find the opposite pattern, isn't it? Which is also, I think, your first main conclusion that you draw. And to me, it feels like very contradictory. On the one hand, you have a higher theta activity indicating that you belong to the ECT group. On the other hand, you also, at least you show a stronger response, at least for antidepressants. So this. Yeah,
and if I could just open the graph, because I think I'm visualizing it, but I'd like to just see it.
So figure 2 on page 59, I think you mean, yeah.
Yeah. Well, with the remitters versus non-remitters, when you look at ECT versus antidepressants and psychotherapy, they definitely are much higher for the remitters and non-remitters. That's
yes.
Yeah. But I agree with RTMS. It's it's a little bit close. It's a fair point to question it. At the moment, I don't quite know how I would then redo it to make sure that whoever, like, it would then really be looking at exactly how many treatments they did before, and what kind of treatments, and if they failed or passed, like, or did better, and then are still just coming for after a relapse or coming, and just going even more in depth for each patient, and seeing,
I could imagine that you would actually trust more in the figure 2 data, because they got this treatment and you had a pre and a post measurement. So this seems to me an excellent indicator of resistance, at least to this treatment. Whereas the group comparison is perhaps flawed. There's a number of potential confounders there. You also mentioned them in your discussion. So do you agree that you would have more faith in your figure 2 outcome than in your figure 1, or?
I think they just, they do, what is it, 50? Yeah. It is, it's, yeah. Yeah. I don't know how I would look at figure 2 as being, whether it's more substantial versus the figure 1. Yeah.
Yeah, for me, the crucial question is treatment resistance can only mean one thing, even if you have different ways of manipulating it.
You can have a brief answer to the question of Professor Smulders.
Well, what I do like seeing in this figure 2 is that even as for after treatment, there's still an increase in RCC theta. So it still comes back to the same conclusion that I think that RCC theta activity is showing treatment resistance. So for that, I could still look there. Yeah.
Okay, thank you.
Thank you for your questions. And Amourie Prentice, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense and your presentation. And I request that you and your company remain here and await the results of our deliberations. Thank you.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gather Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and night. Long road to the south side. 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and night. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Amourie Prentice. The degree committee here present has assessed the quality of your thesis and your defense, and in view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zak is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Amourie Honor Josephine Prentice, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Yes, Amourie or Dr. Prentice, congratulations to this great defense and a great PhD thesis and an incredible achievement. I want to also thank, of course, Maintenance and the Brain Clinics and Seneda for the great cooperation. It is a real pleasure to work with all of you and an honor, and I learned so much, and it seems like that you are the last one of this cooperation, and it has been really quite a journey. But also for you, it has been quite a journey. And of course, I'm happy and thankful that I could play a small part in your journey. I don't want to overestimate my role, but the interactions that we have via email or discussion during conferences or so was always very enjoyable. I got to know you as an extremely talented researcher. Very passionate for the field, very curious and creative, and an incredibly kind person. So it was really a pleasure to think along and to exchange ideas, and you were always very receiving all the feedback in a wonderful way. So that was really, really nice. Before I give the word to Nikita, who will speak the laudatio for you, I also want to tell you once more that I deeply respect your achievement also, because you managed something that not many people have to face as a challenge, because you not only finished your PhD, which everybody that ever did that know how hard that is, how long, with ups and downs, and you need to have that resilience. But in the same period, you also did another life-changing event, which is you started your own family with your beautiful family, your beautiful son, Catherine, and combined this in a incredible way. And I do remember, it's probably very inappropriate to mention this here because it could send mixed messages, but there were at one point when you were struggling a bit, there were pictures that I also saw where you were actually literally in the hospital bed. I don't know whether you're still waiting for labor or recovering from it, but you were with your laptop submitting a paper, literally.
Yeah,
you know?
yeah. They had just induced me.
Yeah.
And then submit the paper.
Exactly. I want to say it's amazing, but in these times it's a dangerous matches to stand. So it's not expected. It's not expected for PhD students to go that far, but you did, and it shows your commitment and your work ethics, and it's quite incredible. So congratulations, enjoy, and with this I would like to give the word to Nikita for your laudatio. There she is. We'll have to wait until you are unmuted by the tech support. Or are you muted maybe, Nikita? No? Can you maybe do it without words, the laudatio? Like, oh, I think now we have sound.
Okay, so this is hearable. Good. Yeah. All right. So unfortunately, from the north of the Netherlands, remotely, I would have loved to be there in person. But still, with the same emotional, how do you say that, betrokkenheid, I want to speak this laudatio for you. I have a bit of an echo, so that's what I hear. But here it is. Dr. Prentice, Amourie, Lokwenske, gefeliciteerd, congratulations, felicitation. What an honor it is to be one of the first to congratulate you on your dashing new title, Dr. Amourie Prentice. Back in late 2020, we were looking for a new PhD student at CINEDA, and with you, we proudly welcomed our very first international in our midst. You came with an impressive resume, and one that would surprisingly later grow a tiny, tiny tail. It took you a whole year to reveal that shocking little twist, but I'll get back to that. First things first. At CINEDA and Brain Clinics, you dove into a project involving the coordination of the EEG assessments and a lot of data management. In Friesland, of all places. A region in the Netherlands not exactly known for being easy to ground yourself in, especially when you're from a neighboring country where speaking the same language literally doesn't equal speaking the same language culturally. Yet, you went for it. You rented a beautiful flat in Heerenveen and slowly but surely worked your way into the clinical team. That came with insecurities, of course, because how do you recognize appreciation in Frisian? Luckily, from our side, it was clear. You rolled up your sleeves, or as we say in Dutch, je zette je schouders eronder. You managed to fully kick off the second wave of data collection and enable colleagues to contribute to it. You worked with such precision and structure that some data sets remained off limits to the rest of us. And it left us with quite a few data aggregation puzzles later on. All the while, you brought your Belgian flair, enriching our vocabulary with beautiful words like plezant, ambetant, and frigo. Unfortunately, we've been missing those words and you for the past 2 years because things didn't go as planned. Then again, that seems to be a PhD tradition, but yours is one for the books. Remember that tiny tale I mentioned? It started with a certain anonymous boyfriend in Canada, someone working at the same university you once spent time at. And because we were this close to finding out who it was, because we were about to fly to a conference in Charleston where he would be, you figured it was time to rip off the Band-Aid. You basically had a quiz that had us all guessing, it had us all gasping, then it had Martijn running for his phone to immediately fact check with Jonathan, Professor Downer. That same conference marked your first big international presentation where you showcased results that, for the first time, included our psychotherapy data. But it was also the moment where we all had to admit You were not joking. Fast forward to early 2023. You had to decide that coming back to work in Heerenveen was no longer an option because of a surprise you lovingly called Catherine. 9 months of severe pregnancy nausea limited you in almost everything, where in hindsight, you don't understand how you managed to still work on your data and writing projects, because somehow you still did. Whether in Luxembourg or Canada, you stayed determined to get those articles written and submitted. One moment in particular, but which Alex already referred to, left us speechless in our WhatsApp group. You sent the picture from the hospital, belly strapped to all kinds of monitors, a laptop in your hands, finishing up a submission. It worked, and then the next day, Catherine was born. In that year, we sadly agreed that continuing the EEG project was no longer feasible. But you found a new opportunity in TMS research. By teaming up with Neurocare in the Netherlands and Long Island, and with Salience clinics in Texas, you were once again working with real-life clinical data, this time focused on OFC TMS. That research brought something out in you, the desire to deliver science that clinicians can use in their daily work. Seeing others in the field with their enthusiasm sparked your own fire even more. Something that, from what I can tell, is slowly becoming a bit of a family affair. And so, Amourie, today we get to celebrate you receiving this well-deserved title. I'm curious to see where life will take you next. I heard whispers about a clinic in Toronto, but I'm hoping not being too forward here. I imagine that it will have a nomadic touch, a family spread across three countries and 2 continents. Whatever the future holds, know that everyone at CINEDA wishes you all the best. We're very proud of you, and we hope you'll keep us posted on your next adventures. Congrats, Dr. Prentice.
Also from my side, and also on behalf of the faculty and Maastricht University, I congratulate you with the degree that you earned today. I want to congratulate your team of supervisors. I want to thank the Corona here present for the questions that I'm sure you enjoyed. Of course, after this we will celebrate. There will be a reception outside. Before we do this, there will be some pictures. So I'm sure that there is somebody in the audience who is a qualified photographer and who likes to stay behind here while the others are already going to enjoy a few drinks. And then we will take some pictures here with you, the Paranymphs, everybody here, your future partner, husband, and we will take pictures here and also on the stairs. So with this, I end this academic session. So those who are online, you can actually maybe stay and hang out because there will be some sort of way to actually still have you in the picture, I think.
De promotors.